Thank you for joining us today. My name is Jeremy Mitchell, and I lead the marketing efforts here at Healthtalk A.I. And I just want to thank everyone for joining us. And we're really excited to have Dr. Elizabeth James. She's the director of Emergency Medicine and Telehealth Strategic Solutions at Keystone Healthcare Partners. And we're excited to have her join us today. She'll be sharing how their associated hospitals and ED practices are using the Healthtalk A.I. platform to inform their decision-making and impact the care that they deliver. We're also excited to have Melissa King with us. Melissa is the Senior Vice President of Client Services and Telehealth at Keystone, and she'll be joining and contributing to the conversation at some point and also be available for questions at the end. And last but not least, we have Jared Uli. He's the CEO and founder here at Healthtalk. And he'll be here to answer any questions you have. So that'd be any platform related questions. He'll be a good source there. And so on that note, as far as housekeeping, at the bottom of your little portal, you should see a Q&A icon. So at any time, just feel free to put your questions in the chat there. And we'll get to as many of those as we can following the presentation. And if for any reason we can't get to your question, we'll do our best to follow up with you directly. So at this time, I'm going to go ahead and turn things over to Dr. James.
Okay, thanks, Jeremy. And I'm so happy to be here. This is like one of my favorite topics to discuss. And just a little pitch about Keystone Healthcare Partners. That's the company that I work for. And we partner with Healthtalk A.I. And have done so, I think, probably about 3 years. I know we won't have time to talk about all of our programs today, but we are so happy that you're here. And if you have any questions, please don't hesitate to get on our website and look around. We've got so much on telehealth. Let's get started. So let me advance past. The title today is A Physician's Perspective on How to Gather, Analyze, and Use Patient Experience Data to Impact Care in the Emergency Department. Unfortunately, on surveys, the use of patient satisfaction surveys in emergency departments has been controversial since their inception. And if you're going to be dealing with physicians, they will likely let you know this at some point in time. So you really, I think everybody in healthcare, including the physicians themselves, needs to understand how we use surveys, the pros and cons. And we also need to be armed with the explanations and reassuring responses that we can give them on how we individually collect that data and how we make decisions on how we're going to affect the patient care experience. I won't have time to go in detail with this, but I do think that it's very important that anybody dealing with the emergency department and patient satisfaction, that you familiarize yourself with the American College of Emergency Physicians policy statement that was originally created in 2010. And it kind of served to address the controversy we have with surveys. And it's a pretty detailed 2-pager statement, and they actually revised it this year. So you can find that on acep.org and under their clinical policy statement section. And so yeah, definitely definitely print that out and be familiar. And then that addresses half of the issues that you'll have with any type of physician that's going to give pushback regarding the validity of any of your surveys. So and I just want to say, like, at Keystone, we looked at every type of survey company and ultimately chose Healthtalk A.I. because they have extremely intelligent technology that helped our hospital clients and clinicians better grasp the patient experience. And after 3 years of working with them, they're the best. So I'm glad that was a good decision that we made as a company. So as the ED director and ED clinician, I'm cognizant, and I've already mentioned this a few times, that surveys do indeed lack validity, and therefore the data produced in the past has been interpreted incorrectly by even our hospitals and our quality departments. But they're here to stay, every indication of that. And we know that the reasons for that are because with value-based care, reimbursements tied to it now. And the surveys are really one of the few tools we have to be able to gauge perception of the care experienced at our hospitals and in our departments. So we can't just say that surveys may not be valid. And so the bottom line is we need to make sure our surveys and how we're collecting our data, we're doing that in the right way so we can make the right interventions after interpreting all of it correctly. So moving forward, I think we all need to like pause. I don't, you know, is a wide range of, I think, people that maybe have joined today that do different things for their hospitals. But I think everybody needs to understand answer these questions for themselves. Number one, are you obtaining the best data possible for your patient experience? Number two, do you understand your target audience? And number three, how are you implementing data-driven change? I mean, we'll go through what we've done at Keystone, but really you need to be familiar with what you guys are doing. Most of our hospitals used HCAPS and still do, and Press Ganey, but unfortunately they're just not, that's not the best possible data to drive improvement. And so I think that's really important to know as well. So let's move to the next slide. When I attempted to answer those questions for Keystone about the validity of the data we were getting, these were the thoughts that I had. So oftentimes, like our hospitals, and they range from very, from larger to very small, but they would give me these surveys and there'd be like anywhere from 3 to 20 for this large amount of time, and asked me to help them with improving patient satisfaction. I couldn't draw conclusions from it, and I couldn't bring about any changes with our clinicians using what they had because it just wasn't valid, and the clinicians know that. And so a lot of the survey companies, they'll only do like 25 to 30 surveys a month, regardless of the size of those emergency departments. And then they'll claim that the results are adequate for statistic validity. And there is a threshold at which data does become relevant, but it doesn't mean it's the best data available. And really, so this gets a little complicated, but in order to create a 95% confidence interval, meaning we're confident with the data we have in front of us, I know in med school we had to all take a statistics class. We would need 175 to 225 surveys to get closer to that 95% interval. And that's just like a few questions there. So when the hospitals were giving me like 20 and 30 surveys, it's just not enough, and we couldn't do anything with that. And the second thing is many survey companies, they don't include acutely ill or injured patients who are admitted to the hospital or are transferred. But that makes no sense to me as an ED physician or director, because what you have remaining are the discharge patients who are lower acuity patients. And while we want their experience to be great too, I mean, we were trained in critical and acute care. We need those other results as well, because the discharge patients, a lot of times we devote disproportionate times to those patients versus the critical care patients. We want to know how we do with everybody is the bottom line. And we were trained for critical care and acute patients. And when they're left out of surveys, I mean, you can't make changes to get better at what you do and what you were specialized in. And then the other things were factors leading to poor patient experience scores. We know that they're including wait times. That's can be outside of ED operations. It's outside of the control sometimes of the staff working in the ED. And so, like, for instance, hospital diversion, we all know that a lot of times that has to do totally with the inpatient departments and their processes and procedures, and it less to do with emergency department visits. But we know wait time is a big factor in patient satisfaction. And so we can have the best processes in the world, but if other departments don't have theirs as well, and we're just all overwhelmed, how that is affecting our patient satisfaction scores. So we need our administrators to understand, we provide them with good data so they can understand how we all interact with each other. And I'll go into that in a little bit in some of these slides. So a few years ago, I was really tired of sitting in these meetings with all these hospital clients going over the Press Ganey and the HCAP scores that didn't really provide me with what I needed to make the change. And so went to every big conference available, found Healthtalk A.I. and Jared, the CEO, and he is lockstep and key with me on improving patient surveying and improving patient care. And it's been, like I said, an easy partnership. And then I thought, so the big thing was convincing our hospital clients to adapt to this. Like, it's one thing for me to pick it out, but another for hospitals and everybody involved to say, yeah, that looks great as well. We presented it to all of our the clients that wanted to make patient experience improvements, and we had 9 of them sign off immediately on this. So they've really embraced this concept too, and nobody's left. Like, they all love it, and we have been making changes, and everybody's just really pleased. So now we have the stuff to move the needle. So going forward, I'm just going to kind of show you. So we call our products, like, we've white labeled it. It's Keystone Connect, and we add a few different things that are outside of Healthtalk AI, but they provide us with all the technology and data ultimately. So this is going to be an example of text messages our patients receive. And so their answers to kind of determine what the next question will be that is asked from them. And that's kind of where the AI comes in. So if we think of it as HCAP surveys in real time via text message, but with the added ability to intervene and change any negative comments immediately, or ask a different set of questions depending on how they're answering. And so if the patient is not satisfied, now we have the ability to intervene and do the patient recovery and offer them an appointment with one of our nurse liaisons or patient care advocates. And then that allows the patient, let me advance so you can see the second set of questions here. That allows them to then determine, set up the appointment and then meet with somebody to go further and into detail regarding why they were dissatisfied. So, and you can see this is like my mission control for our Keystone Connect program through Healthtalk AI. And you can see that these 9 hospital clients that have adopted it, and some are individual clients, some are hospital systems, but the point here is to look at the amount of patients in a relatively short period of time where we have interacted with them and gotten surveys. It's a very large number. So and for the clients, typically I tell them, like, the first 6 months we're just gathering data so that we can increase our N, and you can see the N in quotes there. Really all that is like the number of surveys that we have. It's just a statistical term. So you can see our N's are large. So now we know we have some valid data to work with. And so once we had that, then now we're getting into the weeds where, like, Healthtalk AI and the AI, it'll slice and dice some of the data. So so this is where we're at the part where how are we going to interpret all this stuff. So it'll run the reports instantaneously for us, whereas before you had to do it on pen and paper. So bonus, saves a ton of time and recognizes trends that we wouldn't even recognize without the technology and the artificial intelligence. So it's just fascinating to approach. So the next few slides kind of show you how we can sort this data instantaneously by their chief complaint they come in with, the ethnicity, their gender, the location, the payer, provider, race, you name it. They slice and dice the data on the different subcategories of patients and their satisfaction experience scores. So, okay, so here we're looking at chief complaints on the left, and then their associated perception of the experience. And in that, so, okay, so you can see, like, this slide has like 3.2, 3.1. So I need to explain our 1 through 4 scale to you guys. So number 1, it would be like, hang on. So specific, 3 is good. Okay, so 4, we've exceeded their expectations on the patient experience side of things. 3 means we've met expectations. 2 means we're below expectations. And 1 means very bad, we're far below expectations. So you can see here with this data, if you look at this chief complaint, they're coming in with headache. We've got 53 surveys over here. That's, after a certain amount of time, these will climb as we monitor the data, but we can see we're doing good with headache patients. They're meeting. We could always do better. We could try to get up to 4, but we are meeting their expectations there. But then if you look here, same hospital, now let's see, where do we need to make improvements if we're just going to try to, like, make interventions on people coming in with certain chief complaints. And so you can see here, like, maybe shortness of breath, maybe we need to look at respiratory therapy response times, or maybe respiratory therapy has been lagging and we need more respiratory therapists. So we need to be able to have data to show the decision makers in the hospital why that would improve patient experience, because our shortness of breath patients, we've got 46 of them here. out of, almost 5,000, but still, as you climb, you'll see how like you can work with the data. We need to improve their experience is the bottom line as a group, as a company with you guys, in partnership. And so endless possibilities here on how we could intervene. Just depends on, the hospital specifics and what it is that the administrator expects and the department needs. And so the platform does allow us to address what the survey companies do not. And we can now get information from all ED patients on Healthtalk AI, including those higher acuity patients that I mentioned earlier, those that are transferred or admitted that we aren't getting with some of the other survey companies. So you can see here that we can now implement strategic processes based on these fully acute patients. So let's now, maybe when we have this data looking at it for this hospital, we need to discuss how we improve discharge patients. I mean, they're at a 3.3. Our admitted patients are happy. 3.6, that's pretty close to far exceeding expectations. But maybe we need to look at transfer processes. Let's say this number was like a 1 at your place. Well, we need to figure out how we improve their care experience as well. So I hope that makes sense. But it's really satisfying. I think like sometimes when you charge with quality or improving patient experience, it's overwhelming. This breaks it down into bite-sized pieces. You're only going to focus on transfer patient processes and watch this number in real time improve while you make your changes. Super gratifying. So anyway, and then finally, as we work in systems, we all work with other departmental issues. I think I mentioned that before, but in other words, someone else is generating the patient complaints that we have to spend all of our resources in our department resolving. So we need to figure out, how do we address the decision makers? Sometimes that's a CFO, they're number people, they love this stuff, or a CEO, or department head, just depending on what your position is. And so Healthtalk AI technologies allowed us to, we can present now to C-suite leaders and we help them make it makes their decisions easier. And so let's look at an example of that. So okay, so let's just say we're dealing with a hospital administrator, and they're considering wanting to add, buy up other hospitals in different zip codes. And they want to know, they need data to know, like, well, what's the patient experience from those patients with that zip code, if that makes sense. So you can look here and give them the data, and that'll help them determine if it would be a good idea to expand their hospital footprint into different zip codes. And they can actually take these patients and get more data that you can keep drilling down to answer whatever question it is that they would have about that. So the other thing we've done too, which is kind of cool, is like, so some of these zip codes, if you look at them and you're familiar with them, and like, well, like 3, 9, these are pretty satisfied patients. But let's say you've got some zip codes that have a high end number, but they're at like a 1 or a 2. Well, maybe they're, why is the question. So like maybe, and how are we going to fix that? Maybe when you drill down, you see that they're the driving distance is far. They don't have anywhere to go get care. Maybe you could add like a virtual telehealth component. And I think HAI does have that capability. Maybe we could do that, and we could teletriage them from a distance. I mean, we've done that with other hospitals, and fix that experience for them. So all kinds of cool stuff with this data. And then at this facility, so like I could go on for hours. There's so much to like look into all the data, the way it slices and dices it. But do we need to improve cultural competency, or maybe language services to Hispanic patients, or do we need to address implicit biases with providers? Perhaps we need to partner with HR if we have a low satisfaction rate with the specific subcategory, to see how we can offer specific education with patients that are less satisfied within those subcategories. So all to say, these things can help you really look like a rock star at your hospital when you have all this data at your fingertips. It's super powerful. So okay, now we're going to address the hardest topic, and that is physicians, and getting physicians to change behaviors that have been ingrained for years but need to be uningrained. This is the hardest part of being a medical director, or a hospital administrator, or even a nursing director who has to deal with them all the time. So we know that the annals of medicine are replete with stories of the failure of technically excellent care delivered by unapproachable physicians, and also the success of technically poor care delivered by very charismatic physicians. And there's little evidence in the literature, there's some, but little, that links greater patient satisfaction perception to quality. I think as AD physicians, we're challenged that we must interact with our patients without the benefit of any established physician-patient relationship, although some of ours are repeat customers and we do have established relationship with them, but we have to inspire confidence and communicate their concern for the patient and family our concern for them in a very short period of time. And that's a different skill set from the clinical practice. And that's what is true art of the emergency medicine subspecialist. So can you change that physician's art? And yes, you can. And we've done that. And I'll tell you why. But you need to know, and I'm sure you do know, that you're dealing with data-driven people who are busy, they have little time. And so we want our patients to have good experiences. Most of us have huge hearts, and we just need it painted for us what we're doing wrong. And it's imperative that we provide these docs with individual performance data regarding their experience generated from valid survey data, like the data HAI provides. And we do this with Healthtalk A.I. It allows our physicians to see how they're doing in real time. So you can work your shifts Monday, Tuesday, and Wednesday, and by Friday, you can see how those patients responded to the care they were given. It's it's fantastic. And then so not only can they log in anytime to see that, but they automatically get monthly reports that goes to their email. They can view it whenever they want to on their own time. And it really helps our medical directors. It helps them to drive individual accountability. And we do this for our advanced practice providers as well. And we can also give them, and have before, custom tailored, like if there's one that's way off on certain subcategories, we've had that before where physician is like, they're just not doing well with women. I have a little slide on that, but you can give them specific education, that one clinician that goes directly to their report that they get monthly, which is great. And so this is a screenshot. So these are like some of the text messages that the direct patient text comments that the physicians will get, and you guys will get to with HAI. And so you can see the physicians, the cool thing is they're not just getting, this isn't about negative feedback, it's also about positive feedback. We need to increase morale in hospitals. And we get thanked so much. So do the nursing staff, the respiratory therapists on this. They thank them by name, and they think they're talking to somebody when we text them. They think it's a real person. And so you just get follow-up too, like that, which we've never been able to do that before. So now all this data, plus we get the benefits of these great comments. I think some of them you'll see. And so I did want to mention, I thought this was important as a director, that patient experience data alone should not be used used by itself or misinterpreted as what we refer to as medical directors as a peer review tool. That's totally different. Obviously there's going to be complaints that merit further investigation regarding the quality of care provided or the behavior of the provider. But equally as valuable, the clinical quality peer review should be employed in your departments if it isn't already. So at Keystone, we utilize a 360-degree review process, and these are entirely separate from the patient perceptions of care. So to be clear, this data is coming from nursing colleagues, APPs, and other physicians, anonymously collected SurveyMonkey form to our clinicians. It goes out twice a year, and that's given to them in conjunction with this Healthtalk A.I patient experience Keystone Connect data. And we hope that one day this data all comes together on one platform, but right at this point, they are separate for us. And so patient satisfaction data is perceptive, and in almost every case affected by circumstances unique to that patient's particular moment in time. And we have to be open to those perceptions, but be cognizant that the fact that they may have less capacity to understand the medical decision making behind the scenes. And so that's why this peer review process is so you can, here's an example of what our clinicians get in addition to the HAI feedback from the patients. And this is like a nursing survey that they are completing, and then the nurses can answer anonymously for each clinician. Do they think that physician is nice and courteous? Are they seeing their patients quickly? Are they doing a good job with discharge education? And how do the nurses perceive their workflow? The next will show you, like, now our clinicians also get comments from their colleagues. And then if they're working with APPs, the APPs will do that as well, and vice versa. And then everybody evaluates everybody in an anonymous form. And so the data HI does, plus that's patient experience data, plus the peer survey data, that is what you need to implement changes in physician behavior. And once you have it automated like this, it's so much easier than you think. These were the two tools that I needed to drive that change. But we've done a lot of other things that I'd love to talk to you about further. I won't have time, but one of the things that we did to help support our HAI data and Keystone Connect program was that we added patient advocates. We felt like all of our hospital clients, like every hospital, is stretched, and they don't have human resources to provide the additional steps we felt were necessary to help some of these patients with the recovering the patients and truly apologizing. Some of them really need to feel like we listened to them. And so these are the ones, the three, we had a nurse liaisons at first. So if you see some of our video, it may say nurse liaisons, but then we since switched to just patient advocates and have trained them, and that's going well. So they're the ones that are answering these patients' calls. And you can kind of see, like, this is a note that's in the HAI platform that from one of our patient advocates. And we tell them to use a lot of quotes, but you can get a lot of information from analyzing further and the patient advocate data. So these are your really unhappy patients that are offered these. So you don't get as many as you think, but we get over time, it adds up. So these ends are low, but it's after like a month of gathering data, and you can kind of just see that here we're profiling different types. You might think that hospital complaint data, when you profile that hospital, they all have the same issue, but they can be very different in what makes their patients dissatisfied. So you can see, like, on the hospital on the left, that pie chart indicates to me as medical director, we've got more of a provider problem. That's in the blue on that pie chart, but not quite high of a percentage of complaints regarding the nurses, which is dark orange, or the wait times, which are gold. Whereas the hospital on the right, they have a much higher percentage of waiting time complaints and nursing complaints, and less of an issue with providers. And so addressing those issues is going to be different. And I did want to mention, like, sometimes for me as a medical director for a contract group that's working with a hospital, I do see that improving patient experience is going to involve making some changes in, like, the nursing flow or staffing, or even in registration. But that's really outside of the contract that we have with the hospital. I mean, nurses are usually hospital employees. We're a contract management group, so we're not over them. And that really, I just have to have a good relationship with that ED nurse manager, and they have to trust me. And when you have that, it's a dynamite combo, because when we provide our nursing leaders with this type of data, and they're armed with that in their meetings, they can make the changes needed for their staff and for that department. And it's really a win-win for our ED medical director, our administrators, and our brilliant nursing leaders, because they need help right now. Nursing is struggling, just like all of healthcare. And I know Melissa may want to speak to this, but we do a ton to support our nursing leaders at Keystone, including education and a monthly get together, so we can do what we need to support them. But this data may be the best tool really for the nursing leaders. And now I'm going to give you a couple ideas of campaigns based on ones that we've run, things that our hospitals really like. The social media campaigns. We did a gender campaign recently, and then we of course we did a take charge of your discharge with all our hospital clients. So this is really funny. Implementing data-driven change social media campaigns. You need to find out if your CEO is, we found out, like, one of our hospitals that signed on, well, their bonuses were related to social media scores. Go figure. I had no idea, but this the HAI. He was really excited about that because I think it helps his bottom line and his pay. But anyway, social media is here to stay. And a lot of our hospitals, it was like their social media scores were terrible. And I know, I mean, I use social media to help guide some of my decisions. So if a patient has a great experience, you can see on the screen, if they're having a great experience, we ask them and encourage them to share that experience with their community. And it's been, and it works. And we thank them too. And so this is just like this is like a slide showing we had the 2 months of social media improvement campaign for one of our clients. And so you can see here, like on Facebook in April, they had a 3.1 star. And once we turned it on, they only had one new review. And then, but the Google reviews, we turned it on, they had 81 Google reviews and a 2.5. And within like a week of turning it on, they had like 2 months, within 2 months, 7 new reviews. 4 of them were 5-star ratings. One was bad, but and even though we didn't in that 2-month period change the amount of stars, there were so many more positive reviews. And so this is an old slide, but we've done this with all of our clients. None of them gone down. They only go up, and it's pretty, it's a steady improvement, and all the new reviews seem to be good. And if they're not good, we can have our patient advocates look into that and dig further. And so here you can just see, it's just nice because these are the ones that pop up, and it's just so gratifying to make change and to see the good stuff. And I love that HAI helps us with that for social media. And then let's see. Yeah, these were all good comments. Gender campaign. So I didn't know this either, but like one of our hospitals had, I think it's the next slide. So let me show you. Yeah, so you can see here, this is diving deeper into the data, but you can see like in September, our top chart here. I don't know why, I was just curious, like the male scores were much higher than the female scores. And so let me go back. So I did a little digging. I was just curious about it. And this, apparently this is a thing, like a lot of women have worse experiences than men in 9 out of 10 measures in an ED. I didn't know this. And this does correlate with our data as well. The women tend to be younger, arrived by ambulance, have worse mental health, and didn't always have primary care. And so, and this was looking at like ED CAPS data. But then, so we did a gender campaign, and so they're once a month they get their feedback, and I just added a little bit extra and a video, and I think some articles about like, hey, like you guys, like the females were less satisfied this month. And so you can see the next month, and these are like, you looking at your ends, look, you've got 97 and 63 patients, and the first one, it's valid. And so now, even though now at least it even out. And so those are like the little things you can do with the AI. And it helps guide your education to your physicians, and it's interesting. And then you can go back to them the next month. It's immediate to show them how great they did. And so like, it's just all of it's really good. Let's see. This was, the Take Charge of Your Discharge campaign. We did this with like all of our clients. We gave them all the studies that showed that, a lot of times our patients, they're not reading all these discharge instructions we put out. So how can we actually change that at the bedside and drive change? And then it was similar to the gender campaign. You could just watch them all go up once we started giving them their individual feedback and really making an effort to improve how we discharge patients. And it was also a complicated thing because what's weird is some hospitals, it's like the nurses are the ones that are doing a lot of the discharge educations. Others, it's the physicians, it's a combo, and everybody just has their different pattern of doing it. And so to help standardize that was part of that campaign as well, because really our job as doctors and nurses too, but we have to educate our patients. We can't rely on somebody else to do that. And so that helps with discharge. And let's see, I just feel like we're really just getting started. Our hospitals are immensely satisfied with everything that we've done on the patient experience level. And a lot of that has to do with the data we're getting from Healthtalk AI and their technology. But there's so much more it can do. And I almost feel like I've done this injustice because you don't even know all the things that it can do. So I encourage you to meet with them or schedule an appointment with us. And so we can go further into your specific hospital issues and how we could fix those. So anyway, I hope today you left with a better understanding of Healthtalk AI and management companies like ours and how we're trying to pave the way for the future for a strong healthcare, because we deserve and we deserve in our departments to have a good experience as leaders as much as our patients deserve to have good healthcare experiences themselves. And there's few things I know to be 100% true in life, but for me, I do think that one big truth for me is that our healthcare, we need good leaders in healthcare, 100%, savvy enough to understand survey data and what to do with it. So and I also know that we're going to have to incorporate technology to make the changes needed that are necessary. And so many years ago, I began, I wouldn't say stalking, but close to that, Melissa King, who is here with us today. She's our VP of telehealth, and she is a pioneer in telehealth and in telemedicine and has done some extraordinary things. And she also has like a background. She was the president. She's a nurse practitioner. So further depth and breadth there with the APPs that we have to manage at our companies. But also she was a past president of the State Board of Nursing and just brings such a wealth of knowledge. And so I am turning it over to her to give her, so she can give us some more examples of where she feels the future is going and why we're just getting started. Melissa?
Thanks, Dr. James. You did good. I just wanted to hit on a couple of things to make sure in case anybody's asking questions, because we always get a couple of questions, and that is, how are you going to make sure that people respond because people don't respond to the surveys? So one thing that is very unique and a differentiator for Healthtalk AI specifically is they went the extra mile and have produced, instead of a 5-digit code that comes across as a text, they actually go with the area code of the facility that the survey and where the patient was located and where the survey is going to be originating from. So it looks like the message is coming from a real place and not a marketing perspective or a bill collector or something like that, which therefore increases your engagement responses. So I think that is one key differentiator from the rest of the world that is trying to get into this space. The next thing that I wanted to say is you talk about complaints, right? So when you talk about patient engagement, patient experience, and Dr. James alluded to the fact of physician change management may be hard and there's all this controversy and I don't want to see it and people only complain. But what we realized honestly is that we got just as much positive data as we did, more actually than negative, that we're able to give back. So if there is a complaint that comes through and there's not a trend, we're actually able to go back to this data and show the clinicians, well, yeah, there was a complaint here. Maybe it was a bad day. Maybe it was a mad patient. Maybe it was no big deal, but that's not the trend of this clinician. And so that's why they're able to see their data. And they're also competitive, right? So they compete against each other each month whenever they see their survey results and how they compare against their practice analytics. And then Dr. James focused on emergency medicine, but I will tell you that the platform of Healthtalk AI in general is so vast and so incredibly useful and customizable to whatever your practice management needs are, whether that's from a hospital or a practice management group from us. And we currently focus on emergency medicine, hospital medicine, telehealth, and critical care. So those are the areas that we have asked Healthtalk as our partner to implement these survey questions for our patient engagement, but it could go any place, even to the point in a time of we're not able to retain and recruit work staff. Even if you take clinicians out, how do you keep your workplace healthy? And so this is also a survey that could be sent out in a working environment to bring back to those key decision makers and stakeholders within an organization of how satisfied are your workers who sustain your organization and keep it open, right? Because it can't be a one-man band in anything. So just some kind of examples of other things that we've done. So we're focusing to now starting to change to our 72-hour return visit to the ER. How are we going to change that, and which one of our facilities need to have that focus? There's also some care campaigns that are our super users in emergency department that you can get your highest 10 super users and you can focus on those, develop campaigns, and whenever they present to your emergency department in those diagnosis ranges, focusing on those to keep those out of your hospital for 72 hours is key, so you don't get that penalty. And then once you bridge over to hospital medicine, how do we keep them out of the hospital for 31 days so those hospitals don't receive that penalty as well? And there are different questions for those pieces, but as I said, it's very customizable, very user friendly, very patient friendly, very clinician friendly. It's just across the board an agnostic platform that has improved engagement, and where people think that it would decrease the HCAHPS and Press Ganey response rates, it has not. So like Dr. James said, we've been working and doing this for 3 years. It's across our portfolio, and there have been absolutely no complaints of a decreased return of their HCAHPS and their Press Ganies. Actually, they've gone up a little bit because of the real-time intervention from the patient advocates that we have allowing to intervene when there is a complaint or a negative comment or something of concern that the patients needed. The other interesting piece of this is it can go outside your traditional bricks and mortar. So if you wanted to do a direct consumer platform, if you have a private practice and you're not in a hospital setting, but you want to reach out to your community and you don't want to lose your patients, you don't want to have that leakage. How do you do that from a, can you do a direct consumer? Can you do an EMS type platform, which Keystone has done as well, to see, can it come to the local facility, or does it need to bypass to decrease that wait time and keep those beds open to increase the ED flow? And then, as Dr. James alluded to, the teletriage and the traditional matter, and then the post-discharge follow-up, which is where we have focused for the first 3 years, but now are moving into more of the non-traditional realms of what the platform can do itself. So that's kind of what I wanted to say. I guess we are done a little bit early, so I'd like to know if there's any questions. I haven't seen anything in the questions section. Jeremy, do you have any questions that have popped up?
There's one that came up right at the beginning. Let's see, can the system send custom education to providers?
Yes, so Dr. James actually did that whenever she was talking about the where you, if you want to go into it, Dr. James, is fine. I was just going to say that whenever you look at it and see that a clinician is moving down in a specific area, you can send targeted education to those clinicians and watch their scores improve almost immediately.
Mm-hmm. Yeah, I mean, I would say as a medical director, so one of the things that we did do, so I love TED Talks. I mean, just as a clinic, like, it's really hard to read through emails, a lot of data. So I try to make it, when I give them the education, something fun and something that really resonates with me as a clinician. And so, like, there was one guy, he did, this was on when we were improving discharge, I think, I think we went into a palliative care, because part of improving discharge was palliative care. And we went into this whole thing, and there was a palliative care physician that did a TED Talk that is just emotionally, like, overwhelmingly good. And so they knew we were doing this take charge of your discharge, and every week we focused on something, or every month, I think for 6 months we focused on something different. So when they got their report, they got a piece of education. And I just remember one time, I think I called Jared and I was like, I just want to send this TED Talk. Like, I don't want to send anything other than the TED Talk. And that we were able to, I think, incorporate that into the mail out, a link there, and which was good. And so it's not just boring. It's not just more boring stuff that we have to read, because we're bombarded with that. It's so a lot of good. It's a great question. That's one of the whole reasons why we went with it. And then now, what's really interesting, I think, also in line with that question, is that, I mean, because there's always going to be, especially when we take over a new contract, there's like 2 or 3 clinicians that no one likes, and they just want to be rid of them. And sometimes that has to happen. A lot of times that has to happen, but when you talk to those physicians, if they've not provided information about how they're doing, valid information, not just from the patient experience perspective, but their nursing colleagues' perspective, as soon as they get that data, it's almost like the medical director doesn't even have to talk to them. These talks that we have, they get defensive. You provide the data once a month, you know that they're going to get it. It improves automatically. Like, it couldn't be easier, really. That we took that was the hardest thing in management, is is the physician. So as one, I now have all the data from Healthtalk AI, plus the 360 surveys. And anytime there's a problem, you just pull that data. You can have a one-on-one with the physician. If they haven't been looking at it, that's usually the case, then they start looking at it. It'll immediately improve. You don't have to do anything but just continue to give them the data. And if they don't, then maybe you need to start talking about intervention or removing them from the schedule after that point. So
Yeah.
give
I
them the
wanna add
benefit
one
that they
more.
just need to see their data.
Yeah, I mean, it's clear, I think, everybody listening now is what sets Keystone apart. And that is the forward thinking, and the way you guys think about how you deliver care. And this is a great example. So to clarify, we didn't cover, obviously this is really a conversation about how to improve care, really. But what we didn't cover is that the clinician engagement is customizable. They get scorecards that have the positive and negative results every month. And what we did as an enhancement for what Keystone wanted to do was to actually send specific content. And in this case, Dr. James was sending video content if a scorecard was below a certain number. And so they would decide what that number was in a specific question, and Healthtalk can deliver that content based on what the score is. And one thing we had early on was, well, we can send everybody the content, and that wasn't good enough. And so we pressed us, and we're able to actually improve the product based on their feedback to give specific content to specific providers that are below a certain mean. And so that not everybody's getting the same content, only the providers that actually needed it.
Yeah.
And so I just wanted to, help potentially clarify that one question.
Yeah, no, that was good. Yeah, I remember we customized that to say like because we're always like what's cool is the way it ranks the physician. You got your average and then the below average. None of those clinicians want to be in the below average.
Right.
So you just kind of keep pushing that average up. So you're going to get you're below the average. And that's kind of how you form it into a mini competition, but without a lot of pressure. And so we kept bumping that average up into the 3.5s, 3.6. Who cares if you're below average, if the average is like a 3.9 and you're like a 3.8, we're hitting it, but that's how we did it. Like, you're below average, here's your special information of education. And I don't know, it works. I'm just grateful for Jared, grateful to Melissa for her vision as well. And I think the only other thing that, I don't know if we have any other questions, but I was gonna pop on over because I think this was part of our telehealth program. This was a big movement that we started before COVID, thank goodness. But we have so many things, and Healthtalk AI has so many other things. And I think because we all think the same way, we're in about technology and the future of healthcare, and we're positive about it. I would love to show the video if we have time, Jared. Go in and it incorporates Keystone Connect. But it also shows you a lot of the other things that we do. So give me just a second while I pull that one up.
Some of us may need to mute possibly so we don't get feedback.
While she's pulling that up, I will say that, if you are a hospital out there looking for a group, I think you can see how different Keystone is. And the one thing that they're providing, I think she skimmed over it, but these patient advocates on behalf of a hospital, this is on Keystone. And so they're actually doing the customer recovery for you that is incorporated into their care practice. So that makes them very different, for sure, in terms of that. So something that I think Dr. James skimmed over, but that is a service they provide for you, the hospital, which is it shows how much they care about patient experience overall. So we'll wait for that video if you got it.
Yep, I am. Let me see. I'm going to share now. tell me if you can see it, and then I think I just have to switch the, make sure the audio. Optimize clip for audio. Share sound. I think this is it. Okay. If you can't hear it, Jared, if you can't hear it, let me know, because this was a little add-on, but let me play.
Welcome to Keystone Healthcare's virtual command center, staffed by emergency medicine physicians and advanced practice providers who stand ready to supplement on-site staffing and solve your emergency department's pain points. These virtual clinicians are using a state-of-the-art queuing system that connects them in seconds to your emergency rooms, EMS providers, and patients. It allows them to see up to 100,000 patients per year, work for multiple hospitals, and save significant provider costs. Virtual providers are credentialed for your hospital and trained by Keystone Healthcare on telehealth policies and procedures in conjunction with your hospital's emergency department leadership team. Here's how it works. Teletriage. When a patient arrives to your emergency department, they will quickly be seen by a nurse and connected to a virtual Keystone Command Center provider at the simple click of a button as they're being triaged. Once a treatment plan has been made, the patient can be taken to your results waiting area, where the orders placed by the triage clinician will be carried out. This expedited process virtually eliminates patients who leave prior to triage or leave prior to being seen by a provider. Telecollaboration and surge support. For hospital emergency departments with staffing models that contain advanced practice providers, our software allows for quick and easy consultation with ED physician collaborators in the instance that your ED in-house emergency physician is busy. The virtual ED physician and APP will work to develop a treatment plan and disposition with the patient, saving valuable time and resources for your brick-and-mortar emergency department. Keystone Connect. Now it's time to close the loop. 72 hours after being discharged, your patient will receive an automated text message about their condition and experience at your hospital. If the patient responds that their condition is worse or they had a poor experience, they'll be connected to a Keystone Healthcare nurse liaison for customer recovery. This helps decrease unnecessary return visits and readmissions to the hospital. If the patient responds positively, they will be directed to Google, Facebook, or another review site to improve your hospital's online satisfaction scores. This automated AI system can improve your Press Ganey and HCAHPS scores and provides valuable feedback to hospital administrators and emergency departments. It also provides automated provider education based on direct patient feedback, giving each provider a custom report detailing where they're performing well and where they can improve. Keystone Healthcare, more engaged for better results.
Okay. So yeah, I think that's just good, because if you are needing to approach somebody in a decision-making capacity, I know Jared's team also has we use the same company for so he has a very similar one. And I suggest if you just starting with the videos, I feel like that helped to engage the decision makers at our hospital, because they had to see it and then they got more detailed information, and it helped. It was an easy decision for them. So anyway, thank you for having me today.
Yeah, thanks so much, Dr. James. We really appreciate you taking the time to join us today, and Melissa too, to share just the great work you're doing there at Keystone. If you have any questions after the presentation, we do have contact information. So if it's a platform related question for Healthtalk AI, you can direct that to Jared JERROD@healthtalkai.com, or sales@healthtalkai.com. And for Keystone, it would be, let's see, you can do info@keystonehealthcare.com, or I believe Dr. James, yours is it E. James? E. James?
ejames@keystonehealthcare.com.
Okay. And as soon as we have a recording, I'll send that out to all the attendees. And thanks so much for just joining us today. And we'll conclude with that. Thank you all.
Thank you.
guys.
Thank
Have a good
you.
day.
Yep.
Bye.
Bye-bye.
Bye.